All right. So you know how I feel about Farm. Farm is unfortunately a lot of memorization, as you know. It's a lot of memorization, but at least what I wanted to do was talk about the ones I 100% know you're going to get questions on, like without a doubt, and go into some of like the pathophys and then how the drugs fit into the pathophys. And what's good too is this will be a really good review for boards, even if like you just are like, oh, like I need to review like my insulin drugs, my diabetic drug. Those are going to come up so much, as well as the lipid lowering agents. They come up so much. Okay, so this will just be a good review for that, but especially for your exam. All right, so kind of what I did was I did all those glucose meds. So normal insulin physiology, like why do these meds even work? And then go into the type 1 diabetic meds as well as the gestational diabetes meds. Gestational diabetes in women tends to be the same as the type 1 diabetics. It's just kind of like that's what they found works the best for women that are pregnant that have diabetes. They it tends to follow like a type 1 like treatment regimen. And then type 2 diabetes, then your lipid lowering agents. I wanted to review lipid metabolism because I don't know if you've had that yet this year. You probably have, but it can also come up, especially like biochem can be asked on this exam. Like it can be, it's not going to be that much. Like I said at the beginning of this block with you, like maybe 1 to 2 questions. But if they were to ask a question, I feel like they would definitely ask about lipid metabolism. It's just that important, and then the meds, and then I have just a question. I just wanted to give you an example from like each category how they would ask a question. And I found two very, very board style ones that they would ask. Okay, so glucose. So your normal insulin physiology. So remember, insulin secreted by your beta cells in the islet of Langerhans within the pancreas. And remember, when insulin is secreted, it's secreted as like this propeptide. So anytime you have a pro anything, it's going to get cleaved. So we have proinsulin, which is made up of C-peptide and then true insulin. And then when it gets cleaved, we have C-peptide and then your insulin. Sometimes they won't call this true insulin. They'll just be like, oh, it's like this dimer made up of an alpha chain and a beta chain, and then you can see the disulfide bonds like all throughout it. So I have seen that. Sometimes they won't describe true, like they won't say insulin, they'll just describe what it looks like. And you're like, oh, that's insulin. And then C-peptide. And remember all of the things with C-peptide. Like remember if you have like an insulinoma, that would also have C-peptide present. If you have a nurse that's just injecting herself with insulin to for whatever reason, that will not have C-peptide in it. So it's a good marker to see if like insulin is being made endogenously or if someone's just like injecting themselves with insulin. All right, so then the other thing that's really important to remember is glucose uptake, insulin dependent versus independent glucose uptake. And remember, the only receptor for glucose that absolutely depends on insulin. So it's like you cannot take up insulin within these cells. Sorry, you cannot take up glucose within these cells if insulin is not there, is GLUT4. So remember, GLUT4 is only present, it's not present on every cell, it's only present in adipose tissue and then like your skeletal muscle, your striated muscle. So I think of this as like exercise. Exercise is really, really good at stimulating like insulin dependent glucose uptake. And when you're exercising, it makes sense that your muscles would need glucose. And it also would make sense that even your fat storage would need glucose because it's like, okay, I need energy. I'm trying to break myself down with this exercise. So I need energy to do that. So recall insulin's a hormone. So sometimes they'll ask about like the physiology of a hormone, right? It gets released into the bloodstream. And when it interacts with its receptor, remember its receptor, it's not a G protein coupled receptor, it's a tyrosine kinase receptor. We've talked about tyrosine kinases before a couple times now. But remember, anytime you have a tyrosine kinase receptor, when it gets bound by its hormone, it's going to dimerize and then it's going to undergo that cell phosphorylation and then it's going to trigger the signal transduction. Okay, so that's how insulin works. So it binds, number one, is it's going to bind, that it undergoes its phosphorylation. Then remember, it goes through the PI3K pathway. So PI3K. Sometimes I ask this too, just as like, mechanism question. And the PI3K pathway is basically what is triggering that insulin dependent like glucose uptake. And remember, we're only in skeletal muscle and adipose tissue. That's the only ones that have GLUT4 receptors. So that's how that process works. And then it's when the PI3K pathway gets activated, it's going to basically trigger these vesicles to release GLUT4 and put it on the membrane so that we'll have tons of GLUT4 receptors like on the outside of the cell that can now uptake glucose. Okay. And then you also have some stuff happening here with cell growth and DNA synthesis. It's after insulin binds. Remember, insulin is an anabolic, very, very, very anabolic hormone. So remember, it's going to build things up. It's going to, so things like gluconeogenesis, insulin would trigger that. It's going to stop like lipolysis or like breaking things down because insulin's a very anabolic hormone. I would review, I actually think it's a Boards and Beyond video just before your exam. It's like the fed versus fasting state. I don't know I forget what it's called, but I think it's in the biochem block. And it's just really, it's like just very good. It's a very good reminder of like, if you're fed, this is what happens. If you're fasting, this is what happens. And they love to ask questions about that. Okay, so that was like advice that I had gotten from my big, and I had tons of questions on fed versus fasting state.
Review for boards or for this exam? What
Or
did you say
bored,
again?
sorry. Sorry, I know we're in like board season kind of approaching, but that's like all I mean, it's a good one to watch. It's a very short video. It would be a good one to watch for this exam as well, but it's just really kind of going into like the differences between like your anabolic hormones like insulin versus like more of your catabolic hormones like glucagon, for example, is like very catabolic. Okay. And then remember your insulin independent glucose receptors. So these are all the receptors in the rest of the body that work without insulin. So it does not matter if you have insulin there, the body's still going to be uptaking glucose. And this is in places where you would expect like, oh, if I don't have insulin, I'm not going to die. So it's like, the brain, that's a big one. The placenta, big one. Red blood cells, cornea, your islet cells, liver, kidney, GI tract, brain, placenta, sperm, and GI tract. So that's what all of these are. So people remember that with the brick lips mnemonic. And this is, again, all of the glucose receptors that can uptake glucose without having insulin there. It doesn't matter if insulin's there.
So, like, let's say, like, at normal, when you haven't eaten a meal, would all of these other receptors be taking in glucose at a higher rate than the GLUT4?
Yes, exactly. Exactly. And
So,
that's actually why too you end up like those are the first places that end up getting broken down is like your fat and your skeletal muscle when you're in a fasting state.
because that's like the GLUT4 muscles.
Yeah. And that's actually, which is crazy. That's why when people are on keto diets, like the whole idea of keto is to not have like glucose basically. And what's crazy to me is kind of like you're trying to induce ketoacidosis, which is literally what happens in diabetics that don't have insulin, is they go into ketoacidosis, and it's because and that's the whole idea behind keto is like, oh, look, your adipose tissue gets broken down like so quickly. And it's like, yeah, that's happening, but you're also like you're breaking down your muscle. It's just like it's very unhealthy. Like keto is a very, very unhealthy diet, but that's literally how it works. Is it's trying to get these GLUT4 receptors not working so you can't uptake glucose, and then these are the first muscles that get broken down because insulin's not going to be working on the cells basically.
So I know like some people that started the keto diet like last year, they were second years, and I like don't understand because like do you think that like the GLUT4 and the adipose would be broken down first, like most of that before it would reach like the other ones, or do they all get broken down, but this is just at like a faster rate? Because it has to be unhealthy, right?
Keto is very unhealthy. My dad did keto and I was like yelling at him. I'm like, you cannot, it's very effective. I will say it's super effective, but it is like you're just trying to go into ketoacidosis. That is the literal point behind it, which is not a good thing. You know what I mean? But I think you're right. I think like these are going to be the ones that get broken down first because these are the ones that absolutely rely on insulin and you're not even triggering the release of insulin. And then these guys are going to be, going at their steady rates. I know they all have different pKa, I forget, not pKa, that's acids, but they all have different like rates of uptake of glucose, which I know Turco talked about when you were a first year and you watched those videos. But eventually these would start to get, if you do keto for too long, eventually like the rest of the cells would start to get broken down. And that's not good. That's like when people die of like ketoacidosis, basically.
Mhm.
Wild. Isn't it wild? Yeah. Okay. Well, but at least knowing like GLUT4, this is like the one. But again, that's like the premise behind keto is GLUT4 is only on your adipose tissue and muscle. So if we don't trigger the release of insulin, these cells are not going to have glucose, and then they're going to start getting broken down. And again, that's how you lose weight on that diet. It's all about the insulin not being able to trigger these receptors, which is interesting. It's an interesting tie-in. But this is insulin dependent glucose uptake. It's only those GLUT4 receptors. Your insulin independent is going to be 1, 2, and 5. And then insulin secretion, and I'm going over this because this is, again, one of the drugs primarily works with insulin secretion. So remember, this is now going to be like a pancreatic beta cell. So glucose is going to come into it. And remember, GLUT2 is on your pancreatic beta cells. So if I go back to this slide, GLUT2, beta islet cells, and those are the cells that are making insulin. So here, glucose is going to come in. It's going to get broken down via glycolysis into you're going to get ATP from it. That's going to increase the ATP ADP ratio because we're breaking down glucose to generate energy. Now we have tons and tons and tons of ATP, and that elevation ATP closes. And this is like your common trick question with insulin, like with the diabetic drugs, is you have to remember that potassium channels close, and that's what triggers the insulin release. Sometimes I'll ask about opening because like calcium channels open, which I'll get to in a second, but potassium closes. And when you close the potassium channels, you're basically not allowing repolarization. Like it's not technically what's happening, but you're not allowing potassium to leave. So now it's like you're messing with the membrane potential, and now the cell will depolarize. So depolarization occurs, and then once the cell depolarizes, the calcium channels open. So we have calcium channels, now they open, increases, which calcium comes in, and then we have this increase in calcium in the middle of the cell, and that triggers exocytosis of just insulin chilling, in these little vesicles, and then it gets released, and it gets released as pro-insulin, and then that whole thing happens with the breaking down. But it's potassium channels close, calcium channels open. And remember, some of the drugs are trying to cause potassium channels to close in order to trigger this process. All right, and then again, insulin is an anabolic hormone. So it'll continue to the generation of, energy reserves and glycemic control. And I kind of went through here and went through everything, well, at least these first three, the big three places where energy can, you can build up energy in like terms of anabolism. So with carbs, like how it works is you're directly lowering glucose levels because you're making cells uptake glucose. With proteins, what it does, since again, it's anabolic, it's trying to not break things down, it inhibits proteolysis, so it inhibits protein breakdown, and it actually stimulates protein synthesis and amino acid uptake to make proteins. So again, anabolic. Lipid metabolism, it's going to stimulate fatty acid uptake and lipogenesis, so the generation of new fatty acids and whatnot, and it's going to inhibit lipolysis, so the breaking down of lipids, as well as inhibiting beta oxidation. So remember, beta oxidation is going to be of those free fatty acids. It's going to inhibit that as well, because that would be breaking down fatty acids. Insulin's not about it. And then don't forget that insulin, we're going to talk about this with one of the medications you have to supplement with glucose, and you have to monitor potassium. Because remember, it's that one Costanzo picture that if you give insulin, potassium moves into a cell. Okay, that's just like what insulin does. It moves. So actually, sometimes you can give insulin, and my friend said that they've done this before in the hospitals. People will have hyperkalemia, so too much potassium, and they'll give insulin. They'll give these patients insulin to trigger potassium going into the cells, which is interesting. Okay, so then type 1 diabetes, this is going to be, there's some sort of genetic susceptibility, and then there's an environmental trigger. Usually the environmental trigger is going to be a virus, and I put, hey, COVID here because they've been seeing so many instances of type 1 diabetes coming from COVID, which is insane. Like because usually type 1 diabetes, you're a lot younger. And what they're finding is there's like 14, 15-year-olds being diagnosed with type 1 diabetes after they've had COVID. And they're like, that's really strange. And it's probably like they have this genetic susceptibility already. And then COVID was the trigger for the development of the destruction of the beta cells or the beta islet cells.
Questions, like I get confused. Like today I just did questions and with type 1 versus type 2. And I always forget that these are the HLA markers associated with it.
That's
Because like,
here.
so it's like, even though it's like, because you know how they say like type 2 is more genetic?
I actually have that on the slide.
Wait, where does it say that?
Not on this slide, sorry, the next,
Oh, okay.
the next slide. When we talk about type 2, yeah. And I actually think I highlighted it. Oh, I'm going to jump ahead just to show you, because it's like, yeah. my fun fact because it's like it's something I always forget because it doesn't sound, and I feel like they like to ask that because it's just like it's a silly like fact. But yeah, for type 2 has no HLA markers associated with it, absolutely none, but it's still said to be more genetic than type 1.
Are there markers associated with it? Like
No
anything associated?
markers. The only reason they say it's genetic, I think when they say it's like more associated with genetics, it's like if your mom or dad had type 2 diabetes, you're at a higher chance of having type 2 diabetes versus if you have HLA, HLA-B, where is it? HLA-DR3 or DR4, it's like you still have less of a chance of developing it than if your parent has type 2, you have a higher chance of developing type 2 compared to if you have one of these markers and developing type 1. Does that make sense?
Like, when they say like there's an association, like so association doesn't mean that like two
Causation.
random y-
Yeah.
what did you say again? Sorry.
Doesn't mean causation.
Okay. Yeah.
Association is just like they happen to find if you have type 1 diabetes, like these people more commonly have DR3 and DR4 or HLA markers compared to someone that doesn't have diabetes and that they don't have those markers. But it's not to say you can have like HLA B28 or something and still get type 1 diabetes. It's like it's not a causative link to it at all. It's just like, oh, like it's an associated marker. It's like, oh, like that might be something we want to look out for, but it might never happen. But it's tricky. That's why I really think type 1 versus type 2 diabetes, this is like what they like to harp on because it's such a weird thing that type 1 has literally genetic markers associated with it, but type 2 is considered the more genetic disease.
And I also wonder if lifestyle, like if your
It
parents also
is.
have it.
It is.
And one more question, because
Yeah.
like today I like so like how it says like it's autoimmune.
Hmm.
Like is it always going to be antibodies against these beta islet cells that consider it like that classify it as type 1? Because sometimes like I'll
Not
choose that.
always. Yeah, not always. You can also have sometimes I've seen questions with like people with pancreatic cancer. So it's like patient has pancreatic cancer and it's like they do the Whipple. So they take out the head, right? So they just completely remove the head. It's like that patient can develop type 1 diabetes because now they just don't have beta islet cells or they don't have as many. So it's like that can trigger type 1 diabetes. But it's like whatever just gets rid of the beta islet cells, that can trigger type 1 diabetes.
Okay, got it.
But more commonly, it's like you have this genetic susceptibility, you again associated markers, but it doesn't mean if you don't have these markers, you can't get type 1 diabetes. You can still have B28, you can have A1, like you can have any HLA, but it's just more commonly they see if you have DR3, DR4, you're more likely to get it. And then there's usually a trigger. And before COVID was a thing, the common virus that did this was mumps. Mumps classically caused diabetes. And the reason why is because what does mumps do? Mumps invades glands. That's basically what the pancreas is, a bunch of glands that secrete stuff. So, and again, it doesn't have to be mumps, but they just, again, before COVID, it was like always mumps. That was like the viral trigger of type 1 diabetes,
That makes
especially because it's way more common in kids. Like type 1 is a lot more common to get that in like childhood, and that's usually where you would be exposed to mumps if you're not vaccinated against it.
sense.
Interesting stuff. But yeah, that's actually glad you brought that up and got a question on it and like probably got it wrong because that's what they will ask. They will ask like what's like here like compare and contrast, and it's like, "Oh, type 1 has HLA markers associated with it. It's probably more genetic." And it's like it's not, which is so funny to me. And there's no genetic markers. There's like it just seems like there's no genetics involved with type 2, but it's the more genetically like susceptible one.
So strange.
They do it on purpose, I'm telling you. But again, it's because, and I think they really mean genetic in the sense of like if your parents have it, you are gonna have like you have a very high chance of having it. And I think it's like what you said too, though. It's like lifestyle. It's just it's high BMI. It's like things like that is really what's gonna be triggering it. But okay, so what is basically causing all the symptoms of type 1 diabetes is absolutely no insulin at all. So if I don't have insulin, what's going to be manifesting as like the things that you see in a patient is not having glucose. So we're going to have decreased glucose uptake into the cells. And again, this is like where I know people get like not confused with diabetes, but I think people think like, oh, diabetes, there's tons of glucose, right? Because they're like, oh, it's hyper, like if you have so much glucose, you probably have diabetes. And you have to remember there's hella glucose everywhere, but it's like the cells can't use it. So you almost have to think of type 1 diabetes as like a glucose deficiency. So then back here, it's kind of like thinking about like, and also not having insulin. So you don't have these things happening, but also your cells can't use glucose. So they can't make energy for themselves. They're dying. Like all these things are happening because they can't use the glucose that's there. So it's like another thing to remember. It's like, yes, tons of glucose in the blood, but the cells can't use any of it. So you almost have to think of it as like a glucose deficiency, which is again wild because it's like glucose is 400. You're like, oh my gosh. But yeah. But we'll go into it, some of the symptoms you see. And then so the type 1 diabetic meds, this is going to be for your type 1 diabetics, obviously. But like I said earlier, your gestational diabetes patients. So like your moms with that developed diabetes. And I think that's something really interesting is like when you're pregnant, you can develop diabetes and then you give birth and then like you don't ever develop diabetes after that. I just think that's so interesting. But they treat gestational diabetes like type 1 diabetics. So almost like if you see a mom with diabetes in like a question stem, just like in your brain, just be like, okay, this is gonna be like they're gonna ask me something that's gonna be similar to a type 1 diabetic something. So even like with a mom with type 1 diabetes, it's like what drug do you give them? You give them insulin. So it's kind of like that, which is again weird because you wouldn't think that because it's like, well, their beta cells are probably fine. And it's just something that they found. They've just found like they do a lot better with insulin than if they were to give like a sulfonylurea or something like that. Okay, and then the different types of insulin as well as MPH, the rapid acting, short acting, intermediate acting, and long acting. What they want you to know is like you have to know the names of all these types, and then when would be like the indication to give one versus the other. So that's what we're going to talk about. So your rapid acting insulins is they're going to peak 1 hour after taking. And I had in my notes as well, the reason why they like peak so quick and then they're like out of the system is because they don't polymerize into hexamers. So I'm assuming when this drug is given, a hexamer is like a seven, a seven, that's definitely not a hexamer, but like a seven, pronged thing. And that would make it stay in the blood longer because the longer acting insulins all polymerize into hexamers. So these guys don't. I don't know how important that is to know, but just like that's what's contributing to how short it lasts basically in the body. The three ones you need to know are Lispro, Aspart, and Glulisine. And people remember this with there's no lag. They work like as soon as you give them, which I like. And then how they work is all the mechanisms are going to be the same. All the mechanisms are insulin, basically. So they're going to bind to insulin receptors. They're going to bind to those tyrosine kinases and then just do what insulin does, right? It's going to uptake the GLUT4. It's going to cause the GLUT4 receptors to increase on the cell surfaces as well as cause basically glucose to go into cells. So why would you give a rapid acting insulin? And the reason you would give this is you have a type 1 diabetic patient that just ate a meal. So they just ate a meal and now it's like their glucose is going to spike because they just ate. And you would take immediately after that meal a rapid acting insulin, okay, to kind of counteract that. And a lot of these have the side effects of hypoglycemia. So I tended to just like highlight the ones that were like more specific to certain drugs, okay? So hypoglycemia, obviously you can see that with any insulin you give. Lipodystrophy, because remember, insulin really affects the lipid metabolism as well. Hypersensitivity reactions, and then weight gain. Because again, anabolic. So insulin causes anabolism, so that's going to cause weight gain. Your short acting, this is going to be around 2 to 3 hours after taking. Now we're going to start getting some polymerization, and that's why it lasts a little bit longer. This is your true regular insulin. So you give like regular insulin. It works 2 to 3 hours after you take it. And when you would give something like this is a patient that's undergoing DKA or hyperkalemia. So you don't even need a diabetic patient and you can give them just regular insulin. And this is what I was talking about my friends would do sometimes. Like they found a patient with like a potassium of 5 and they're like, oh my God. And they give them insulin to try and get some of that potassium to go inside of cells. But for type 1 diabetics, you would give this in a patient that's undergoing DKA. Because remember, like I said, that's kind of the whole point of keto is to go into DKA and you're trying to not activate insulin on the GLUT4 receptors. This is also the only one to be administered IV. Do you remember? I was actually going to put this as a question in here. Do you remember why oral insulin is not oral insulin, sorry. Oral insulin is better than IV insulin?
Does it have to do with
There's a hormone. That's your hint. There's a hormone involved oral versus IV.
like GLP or
Yes.
something?
Yes. Cool. So exactly. So if they ask you any question about oral versus IV, they're trying to get at the GLP because it's just better at triggering GLP if you administer it orally. But this one, since it's more life-threatening and it's more like they're in DKA type of thing, you give it IV so it works quicker. You don't really care about GLP at all. You're just like, I'm just trying to get them out of DKA.
What does GLP do again?
So it basically does what glucose does. So it's like glucose-like peptide. I think it's glucose-like peptide. So it's basically just trying to do what glucose does. Okay. So this is the other. So a lot of the times I say like they can't ask you questions about like what would you do next? Like a lot of the times on boards they don't do that. Like they don't ask for drugs especially. They're not like what drug would you give this patient? They try to not do that. They try to do like here's the drug you give, here's the side effect, what drug was it? But this would be the only instance where I would say so like let's say they explain someone with hyperkalemia and you say you give the appropriate medication for that, which would be insulin. And then it's like, what also must you administer? You have to give glucose. Have to. Especially if you're giving insulin for hyperkalemia, that means it's probably not a diabetic patient, so glucose is probably normal. You don't want to like kill this patient by making them go into like a diabetic, like a basically like a diabetic coma because it's like they have no insulin that their cells are using. Does that make sense? So it's like you have to co-administer insulin with glucose, which again sounds crazy. Like, but again, we're not talking about like diabetic patients in that instance, but it's like, why would I give insulin and glucose? You're like, that makes no sense to me. But that's why you're giving it for hyperkalemia, and then you need to make sure you're not like triggering hypoglycemia in this patient. So you give them a little bit of glucose. And then all the same side effects. All insulin has all the same side effects across the board. All right. Your intermediate acting, so this is 4 to 10 hours later. So this like you can take this one time in the morning and then have like 4 to 10 hours. You get the polymerization; it lasts longer. This is your NPH. NPH stands for neutral protamine hagedorn. I have no idea. They won't do that to you on like questions. They'll call it NPH. For some of the lipid drugs I'm going to talk about at the end, um, they will do that to you. Like you need to know the full name. And I put it on there, like which ones you should definitely know the full names for, because I've gotten questions wrong before because I had no idea what the full, like I was like, oh, that's what that was. So this is not one of them. I don't think they're going to call it neutral protamine hagedorn or whatever that is. They'll call it NPH. NPH is what most type 1 diabetics take. Like this is normally what people take. So even like I have like DKA, hyperkalemia here, it's just having diabetes. Like they take NPH. And all the same side effects happen. This is very similar to regular insulin. It just peaks a little bit later than regular insulin. And then finally, your long acting. This is the one that there's really no peak. It's just like steady state. It's always high. This is kind of like, I'm going to jump down, but this is kind of like you wake up in the morning, you're type 1 diabetic, you wake up in the morning, you take this, you're good until tomorrow morning type of thing. It just maintains your insulin all day. But then it's like, oh, like if I have a meal, I need to take one of those no lag ones. So I need to take one of those to supplement. So I say like this is like a steady background level just at all times. Detamar and glargine are the two, long acting. So these are two that someone would just take for the entire day. And then all the same side effects because there's always the same side effects.
Quick question.
Yeah.
So, when with the problem stems where the patient is really hypoglycemic, would that be caused by this long-acting one, or would it be caused by the short or intermediate ones?
It's a good question. I think it can be any of them. It just depends on like if you're on one of the long acting ones and then you maybe take an additional one, that would be more of like a, oh, maybe they're going to go into hypoglycemia a little bit, more. Because I know type 1 diabetics that they just take their glargine and they're good. Like they don't even take anything else. So I think it just depends on how much of the additional ones they're taking, or if this is at too high of a dose, that can definitely trigger hypoglycemia.
But, like, do they need to eat when they do this, when they take this, or no?
So a lot of I don't know if you know anyone that has type 1 diabetes. There's a girl in my lab that has type 1 diabetes, and I learned so much about type 1 diabetes from
Really?
her. I'm not even kidding. But she has this, like, those little things that they wear on the back of their arms.
Hmm.
She has an app on her phone, and it like beeps when her glucose is dropping. Like it'll beep. And she's like, "Oh, I gotta go eat something really quick." And she like leaves lab to go eat something. And she'll call me over. She's like, "Can you finish this for me? Because I gotta go eat something. My thing just beeped at me." So it's kind of like a that's why that's good, because it's like you might not even know your glucose levels are dropping, because it's like that's just how you are that day. I mean, think about too like cortisol. Cortisol really affects your glucose levels, right? Like that is like cortisol, that's what cortisol does. It affects glucose. But remember, cortisol is your stress hormone. So let's say you're super, super stressed, you have more glucose today than usual, and then it's like, oh, I didn't eat that much today, but my thing didn't beep at me. It could be that your cortisol levels are really high. So it's like I think it's like that's why like there's an entire field dedicated basically to insulin, and it's endocrinology. Like endocrinologists like primarily deal with insulin dosing because it's like every person is going to be different.
So with glucocorticoid, if you take that, then it would cause insulin resistance, right?
Yeah, glucocorticoids can cause insulin resistance, yeah.
Oh yeah, so then it would be like you might even need to take more of the
Yes.
medication.
Yes. Exactly.
What does lis lipodystrophy mean again?
It's just like dysfunction of lipid metabolism in some way. Maybe it causes too much lipids, maybe it causes too little. Because remember, with insulin, where's the slide? This one. So it's like lipodystrophy would be an issue with this step. So either too much or too little. So like remember, insulin stimulates fatty acid uptake and lipogenesis. It inhibits lipolysis and it inhibits beta oxidation. So you might have a dysfunction in lipogenesis, lipolysis, free fatty acid breakdown. Like you might have an issue somewhere around there. So they call it, just in general, they just call that lipodystrophy or
Okay.
lipodystrophy. And it's just something to like, again, it's like something to just look for in like a prompt in like a question stem to be like, oh, like glucose is really, really low. And also the lipid levels are really, really high or something like that. And you're like, oh, this sounds like like too much insulin, rather than like pointing to like a specific issue from lipid metabolism. They just call it just basic lipodystrophy. And then here's your chart. So I have seen questions too, where they'll give you a chart like this, point to one of them and be like, what is this one? Or like, which one of these is like your long acting insulin or something like that. So just kind of knowing, I think they know that people hate charts and like just they like freak out when they see a chart. So I just wanted to show you a chart, but it makes sense. It's everything we've talked about. Your no lag guys are going to be first, then regular insulin, then NPH, and then your long acting ones, and kind of where they peak lines up to where we talked about. All right. Okay, so then type 2 diabetes. This is going to be your peripheral insulin resistance. So, the two things that tend to be associated with type 2 diabetes, and usually in vignettes, when they're trying to get you to like to realize something is type 2, they will mention that the patient has an elevated BMI and they'll mention something about lifestyle. Like they'll talk about how they don't exercise much or they don't eat well. Like they'll throw something like that in there. Because again, type 1 and type 2 can sound very similar because it's kind of the same idea as like just no insulin or just insulin resistance. So it's like to kind of know the difference between the two, they throw these little things in there, like the elevated BMI and the life, like just makes it sound like they're unhealthy people, which again is not always the case because it is very genetically motivated. But that's what I just noticed that in vignettes. And also your type 1 diabetic vignette people tend to be a lot younger. Like they tend to be like, in their teen years or like even before their teen years. Those are the people for your type 1. Type 2 is like they tend to be a little bit older. Okay. So what people sometimes forget about type 2 is by far and beyond, like, it's insulin resistance. Like, that is the pathophys of type 2 diabetes. You have tons and tons of insulin being secreted, but you still have all these glucose levels. And it's like, why? Like, why do I have so much glucose if I have insulin that's being released? And it's just no one's responding to insulin anymore. And do you remember what clinical feature is representative of insulin resistance that some people can have, like on physical exam?
I feel like I should know this.
It's okay. You're gonna kick yourself when I say it. I don't mean to put you on the spot. It's just like it's stuff I didn't put in the slide that I'm like remembering as I'm talking about it.
I forget right now.
Okay, acanthosis nigricans. Just remember
Wait,
the
can you get that again?
insulin resistance. That's like a trigger. That's like a true sign of insulin resistance.
But why?
They don't know. They have no idea. And remember, acanthosis nigricans is like the hyperpigmentation of the axilla. It can also be anywhere there's body folds. So, like your stomach, if you're like very obese and you have belly rolls, basically, you can get acanthosis nigricans in your belly rolls, which is so funny to me. But that's like a true sign. And like, I think we talked about with some of the gastric cancers, I believe, acanthosis nigricans can be a sign of one of those gastric cancers. But usually, if it's not like a gastric cancer question, it's going to be because they're trying to get at type 2 diabetes.
Okay, got it.
And they won't say patient has acanthosis nigricans. They're going to say hyperpigmentation, of the axilla, back of the neck, stomach, like at the fold, something like that. And they're just trying to get at insulin resistance. Because I think PCOS, right, also has insulin resistance, I believe.
Oh my God, that was another question I was going to ask you, but I thought I asked you too many questions today.
Oh,
But
you never asked me too many questions.
that was my question. It's like, why does PCOS cause insulin resistance?
Yeah, I don't know. I don't remember off the top of my head. I just know that there's insulin resistance with that. It's definitely about the hormone. Like there's something just weird with the hormones. It's kind of like the acromegaly question you asked me today. It's just like you just mess with the hormones somehow. But it's like when I think of that, I automatically think of like, oh, there's insulin resistance, and like, oh, if there's insulin resistance, there's going to be acanthosis nigricans. But I'll make a note of it and then look to see if I have it in my notes. I'm sure there is a mechanism. I'm just like, for me, I'm just like, oh, it's just like, if I see that in a question prompt and it sounds like PCOS, I'm like, all right, this is PCOS. And here's your insulin resistance. I'm like, check, 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 check. All right, so PCOS and acanthosis. Because too, like you can have, again, like we talked about the gastric cancers, like you can have acanthosis nigricans without having insulin resistance. But it's like a lot of the times when you see that just like in a question, they're trying to get at insulin resistance in like some way, shape, or form. But so for this one, they're like, all right, well, what's causing the insulin resistance? And they're like, we don't know, but it's super genetic. Like there's got to be something. There's got to be a lot of genetic components as well as those environmental factors. And here's your fun fact that I already know everyone's going to ask you about is type 2 is actually more associated with genetics than type 1, which again, absolutely boggles my mind. There's no HLA markers with type 2. But it's very, again, look for things like elevated BMI, the lifestyle, if the parents had it, things like that will help you figure out if they're talking about type 2. So this is like the part of insulin resistance that people live with type 2 diabetes for like, they can live with this for like 20 years. But then there becomes a point in this progression of diabetes where eventually the beta cells are going to stop working. They just don't work anymore. And you can think of it, how I kind of think of this idea is like when you have insulin resistance, it's like there's no negative feedback, right? Because it's like the cells are not uptaking the glucose. So the beta cells are like, oh, I need to keep pushing out insulin because like there's just no negative feedback in that regard. You can think of this like when you're in the car driving and the music, you need to turn the music up a little bit more. It's like, okay, I'm going to turn the music up a little bit more. And then it's like, oh, I'm going to turn up the music a little bit more. And then it's like 20 years of turning the music up until like the speakers are like at max volume. And then eventually the speakers blow out. And that's kind of what happens here. The pancreatic beta cells just stop working. The speakers blew out basically. So what's interesting is you can have a type 2 diabetic that's going to need insulin. So one of the treatments actually for type 2 diabetes can be insulin. And I know like people get very thrown off with that sometimes. They're like, why does this patient have type 2 diabetes, but I'm giving them insulin? It's probably like they got to that point where their beta cells just aren't working anymore. So we need to supplement with insulin.
So it's insulin resistance and beta cell dysfunction. But if there's already insulin resistance, would you give, like, you would give two medications, right?
Well, you would give one of those type 2 diabetic medications for this instance, and it's just basically helping either release insulin or like just causing more insulin to be released, which helps get glucose back into the cells. Eventually the beta cells are just going to stop working, and that's when you would just supplement with one of these guys. Like you would give like actual insulin to a type 2 diabetic, but you would probably still have them on their metformin, their sulfonylurea. Like you'd still probably have them on their type 2 medication. You're just now also going to supplement with insulin.
So like what's not responding again when you have increased like insulin resistance? So is it like GLUT4 or just all of them are not
Not
responding?
like nothing's responding. Nothing. And this is like the one where they say like, "Oh, if you have too much sugar, you're going to get diabetes." And it's kind of like you just flood the body with so much glucose. It's almost like they're just becoming like they don't care anymore. It's like, "Oh, there's just tons of glucose here. I'm not going to respond to it anymore." They become like almost desensitized to glucose, which is
I feel
really
like it's gonna
interesting.
happen to me. Like I wonder like how much of like because I run all the time, but then I eat so much sugar, and they have that office in PBL too, and they have candy there.
Oh, I think
So
yeah,
I
I
just
know.
yeah, like I
So,
think I'm gonna get diabetes.
yeah, but if
Like
diabetes doesn't run in your family, you're probably fine. You know why? Because type 2 diabetes is very genetic. Very, very genetic.
oh yeah, that's true.
And that's what annoys me, and like even like cardiovascular disease is just like this. It's kind of like you can have someone that exercises every day, eats so well, like does just everything right, and then they still have a heart attack. And then you have someone that like doesn't care what they eat, they're a couch potato, doesn't move, and they never have a heart attack. And it's just like, why? Like it's just so weird to me that stuff like this happens. Or you have people that chain smoke their entire lives for 40 years, they never get lung cancer. And then you have someone that smoked like for 1 year and then they all of a sudden get lung cancer. It's just there's gotta be that genetic component, but it's just like no one knows what it is. But that's kind of the case with type 2 diabetes. It's like there is a genetic component. So it's like if you eat tons and tons of sugar, but it doesn't run in your family, you're probably fine. Not saying you can't be like the first one, but you're likely fine. Like if I had to guess, I'd say you're probably fine.
Okay, that's good. But like I just assume if we study all the time, our brain needs all that sugar. So I'm probably like
All
it
the
needs
sugar.
it anyway.
Exactly. Your brain is so
Yeah.
happy. That's why you're doing well in your exams because of all the sugar. All right. So with the and the other thing, yeah, so the other thing I wanted to mention is this progression from like turning up the speakers to like blowing the speakers out entirely. It does make treatment a little tricky because like I said, you could give a type 2 diabetic insulin and you're like, why are you giving a type 2 diabetic insulin? Like that doesn't make any sense. But it could be they got to that stage where now their beta cells just aren't working and you need to give them insulin.
I also wonder, like, if you keep giving them, if you give them the insulin like you would give for type 1 diabetics, right? Like,
Mhm.
wouldn't that eventually also lead into the insulin resistance?
I think so. I think so. I think a lot of the times though, it's like by that point they start going into like straight up DKA, kidney failure. Like that's kind of when it's like, oh, this patient died from diabetes. It's kind of like they got to that point where it's just like it doesn't matter what you give them, the body's not responding.
Can you give them, like, because I kind of forget biochem, but could
Mhm.
you give them something else that could be taken up and then just be converted to the glucose they need or the energy they need?
You can probably do that. Like they can have more free fatty acids that can get broken down into glucose. You could probably do that and that's also probably why like that could be a strategy that you do, but again, it's like the body's gonna get tired of it eventually because you're not using what it was like made for in a way. But like I'm telling when it's like people die of diabetes and it's like they don't have type 1, they have type 2, it's because it's like the body's not responding to any medication you give them. They probably went into kidney failure and then they just died from it, unfortunately. But what I
Mhm.
wanted to mention with kind of like with this, the progression making treatment tricky is all of the type 2, so all of the type 2 diabetic medications I'm going to mention, is when we're still at this stage, so this insulin resistance stage, and you can think of this as having functional beta cells. Because once you go to this dysfunctional beta cell level, this is now when you don't even make insulin. You have to supplement with insulin as well. Okay. So initially, insulin resistance leads to elevated insulin. So the patient's going to have elevated insulin. And that's when you give all the medications we're going to go into for the functional beta cells. But over the course of the disease, this progresses, and then eventually the beta cells just don't work, and then you need to give insulin. Okay. So it's just something to keep in mind. You can still give a type 2 diabetic insulin. It would probably be like, they would have to tell you something though, like you measured insulin levels and they were very, very low. But it's like a classic type 2 diabetic case. Like they talk about the elevated BMI, they talk about the lifestyle, they talk about the acanthosis nigricans. Like it just classically sounds like type 2 diabetes, but then it's like insulin levels are low. You're like, and it's like a 50-year-old. So and this has never happened before type of thing. So it's not like new onset type 1. You're like, oh, this is probably their type 2 that's now gotten to this part. And that's when it would like be like, oh, I would have to supplement that type of patient with insulin versus like metformin or something.
Wait, can you say that one more time? What the problem would be again? Like they should have less insulin, you said?
Yes. So once they get to this stage, let me get rid of all my marking. This pancreatic beta cell dysfunction, and this is after like years of living with type 2 diabetes, and it's like, again, the speakers have now been blown out. There's just no insulin levels. Like there's no insulin in their blood because their beta cells aren't working. So you would see that and be like, well, that sounds like type 1 diabetes, but it's not like a 10-year-old. It's not like, you know what I mean? Like they have elevated BMI. They have a weird lifestyle, like a bad food lifestyle. They don't move around. They don't exercise, things like that. It sounds very type 2, but then insulin levels are low. And you're like, that's really strange. And it could just be they had undiagnosed insulin resistance type 2 diabetes, and now all of a sudden the pancreatic beta cells have stopped working.
That makes sense, yeah.
So it gets a little tricky with the type 2s. And not to say, like, a lot of the times with the questions, they're going to focus on the functional beta cells. Like, even on your exam, when they talk about a type 2 diabetic, think about these drugs first. Don't think about giving them insulin. I feel like they would have to specifically say insulin levels are low in this patient for you to even consider giving insulin. Like, it would not be my first thought if I was doing a vignette to give insulin. Okay? So that's why I underlined bolded this, because all the meds we're talking about are going to be focusing on like the functional beta cells. So we're still at this point. We're still at this insulin resistance like point of the disease. Okay. So this is where I was mentioning, this is why people hate the diabetic medications. There are these are the classes, and then each class have names. And this is why people hate diabetic drugs, because there's so many. And boards knows that. And so this is what I was trying to tell you earlier too, is like know the names and know what class they're in. Okay. So, and again, like I said, we're talking about all the ones with the functional beta cells. So we are still at that insulin resistance level. And I found this like little mnemonic in my notes. So to normalize pancreatic function, this is going to be a bulk of these type 2 diabetic meds, is the glits, the glins, the glips, and the glyphs. So to normalize pancreatic function. And we'll go into like which one I have like on each slide, like, oh, this was the glits that I was talking about. These are the glins and whatnot. But if you ever need to, like, if you're ever stuck and it's like there's just a bunch of random drug names on like in like an answer choice, just be like, okay, this is type 2 diabetes. Let me at least start by looking for a glit, glin, glip, or glyph as one of these answer choices. But you're gonna know them, so you're not even gonna go there because you're gonna know these like the back of your hand. So we're gonna talk about biguanides, thiazolidinide. I don't know this one. Your sulfonylureas and meglitinides. These are like the same thing. Your GLP-1 agonist. So we mentioned GLP-1 earlier. DPP-4, islet amyloid polypeptide, and then SGLT2 inhibitors and alpha glucosidase inhibitors. Okay, so these are all the ones. These are the classes, and then we're going to go into the individual. And it's to the point on your exam, on boards, if they mention a drug, you should automatically think of the class. So they mention one drug name, you're thinking of the class because that's how we're going to be talking about it. So for example, metformin, this is the drug that is in the class of your biguanides. Okay. There's a lot to know about metformin. There's a lot of things I underlined, bolded, highlighted, because metformin is probably one of the most commonly prescribed medications other than statins. Super, super widely given. So they like to ask questions about metformin. I would say if I had to pick two drugs to just know everything about, statins and metformin would be my top two. Just because like so many people are on these drugs. So the first thing to mention is metformin is renally excreted. So, and this is like a thing to just kind of know that it doesn't undergo first pass metabolism in the liver. It gets excreted by the kidneys. So you really shouldn't give a patient metformin if they have some sort of renal issue. They have like renal insufficiency, their GFR is like really, really low, something like that. You shouldn't give them metformin. Usually this is first line, again, unless you have some sort of renal issue. Okay, they love this. I'm not kidding. I think every question I've gotten on metformin, they mention something either about the kidneys or not about the kidneys. Okay, so, because again, you hear type 2 diabetes, you're like, oh, I got to give them metformin, have to. Like, everyone's on metformin. And then they mention, like, oh, by the way, this patient's eGFR is like 4. And you're like, oh my God, like I can't give them metformin. So just keep an eye on that. Just remember this. They can even mention, like, oh, patient has like cirrhosis. Fine, I don't care. Like, if they have cirrhosis, I'm giving them metformin because this does not go through the liver. Does that make sense? Okay. So the next thing you should definitely know is how these drugs work. I've gotten questions on, like, first they'll ask me, like, specifically what enzyme do they block or activate? So, for example, metformin both inhibits MGPD and activates AMPK. I have in the little notes what these stand for because these are ones that you should know the full name. I think the M is mitochondrial. I'm blanking what this stands for, but it's in the notes. You should definitely know that. They're not going to say MGDP in a prompt. They'll write out the full name, and you're like, oh, that's MGDP or MGPD. Okay. AMK, they'll just write AMK. But so sometimes they'll ask that. They're like, what does it inhibit? What does it activate? Sometimes they won't do that. They'll just say like, oh, how does metformin work? And they'll have a list of questions and it's like, oh, it decreases hepatic gluconeogenesis. It increases insulin sensitivity. It increases insulin release. Like it'll just have a bunch of those listed and you need to know which ones like metformin does. And this is how all the drugs are, which I'll go into but I basically underlined and italicized in first aid where it has what its mechanism is. So this is like what first aid considers metformin's main mechanism is to increase insulin sensitivity. Okay? But it also has this other component where it decreases hepatic gluconeogenesis because it inhibits this enzyme, this mitochondrial GPD. Okay? So that's like, again, the mechanism is going to be big with these drugs. And it's, again, just memorization, but that's how they're going to do it. And I'll show you again with the questions at the end, like how they're going to word things like this.
The AMPK, where is that? Is that also in the liver?
That's a good question. So if I go back, I didn't point it out, but if I go here back to this slide, it's not in this slide, but the RAS MAP kinase pathway, AMPK is in this pathway. So it's one of the intermediates in this pathway. So it's basically triggering insulin, like glucose uptake. Like it's basically just like making insulin better at being insulin by activating AMPK, which is in this pathway. Make sense? Over here. Okay. Yeah, AMPK is they call it the metabolic sensor of the cell. My entire research when I was a second year was on AMPK. It was like entirely on AMPK. It's in all the cells in the body. It's not just in the liver. It's everywhere. There's probably a lot of it in the liver. But they literally call AMPK the metabolic sensor because it senses like, hey, we need insulin. Hey, we don't need insulin. Like that type of thing. That's like what AMPK's role is. So yeah, it's really important with metabolism. So it makes sense that metformin would act on this enzyme. That's really important with metabolism. So indications, this is your first line. So it's always important to know the first line when we talk about the lipid drugs at the end. Statins are your first line. You know that. So usually, and again, they really won't ask you what drug do I give this patient. They usually won't do that, but if they were to, it would be metformin for type 2 diabetes unless they have some sort of renal issue, and it's going to be your statins for your lipid lowering agents unless there's some sort of contraindication. So it's your first line oral agent for type 2 diabetes. Your adverse effects are going to be, so there's a lot of weird ones with metformin. So for example, lactic acidosis can happen. You have a lot of GI side effects with metformin. You can get a vitamin B12 deficiency, as well as weight loss, which a lot of the time weight loss is not adverse. Whenever there's like a side effect that's not adverse, I like underlined it just to remind you, like, this is probably desired. Like, I actually remember when I started med school, my brother straight up asked me, can I prescribe him metformin when I'm a doctor? And I'm like, why? And he's like, it's just such a good drug. And then you lose weight from it. I'm like, what? I'm just like, what? But yeah, but it is a really good drug. There's a lot of papers that have come out about metformin like being used for things that aren't type 2 diabetes, which is kind of cool. It is a really cool drug, but there are a lot of adverse effects with it. Like lactic acidosis is not good. Vitamin B12 deficiency, nausea, vomiting, diarrhea, like that doesn't sound great. So there are these side effects of it. But yeah, it does cause weight loss. So people are like, oh, like I'll take some metformin, sure. But yeah. Okay. And then remember, it's not completely contraindicated with renal insufficiency, but a lot of times with vignette, I think this is more like real world. In vignettes, if they mention anything about like the kidneys, I would not give metformin in that type of instance. All right. Your next one, your thiazolidinediones. So these are your GLITs. So remember your GLITs, GLIMs, GLIPs, and glyphs. These are your GLITs. So these are rosiglitazone and pioglitazone. So that's where they get the name GLITs. How these primarily work, they work very similar to your biguanides by increasing insulin sensitivity. But here, they don't work by activating AMP-K. In this instance, they work by activating PPAR gamma. PPAR gamma, this is another one. You should definitely know the full name of this. I actually think this is the question I got wrong because I had no idea what this full name was of it. And I also put it in the notes, but I like picked another random enzyme. I think I actually picked AMP-K for how these guys work because again, I saw like the full name of PPAR gamma. I'm like, I don't know what that is, so I'm not picking it. But this is found in like the nucleus of cells, and it's basically in muscle cells, fat cells, and liver cells, and it just increases insulin sensitivity in these cells. Another thing that happens is these GLITs upregulate levels of adiponectin, and I put here what adiponectin does. Adiponectin, right, it kind of regulates glucose metabolism and fatty acid storage. A lot of the times, adiponectin causes increased like fat storage, like in the stomach. So technically you can gain weight from this med. So it's not, some people don't really like this med because of it, but just look for that as like a side effect in like a vignette is like, oh, like central adiposity or something like that. Like they gained weight after taking this medication and it's because of this adiponectin. Another one too is this increases differentiation and number of adipocytes. So it will increase triglyceride storage. So something cool is it actually removes triglycerides from the blood and it stores it. Again, it's storing triglycerides, you're going to gain weight, but in theory, you can technically give this drug to lower triglyceride levels, which is kind of cool. Give it for type 2 diabetes, and then your adverse effects. I have like the weight gain that hopefully makes sense, and then the weird ones that I like highlighted. For whatever reason, these guys cause fluid retention and edema. So a lot of the times you can't give this to a patient with heart failure because it'll like lead to just acute decompensated heart failure because of that edema. And then there's an increased risk of extremity fractures. I'm telling you, I have gotten every question on all of these drugs, and it's like they'll mention, a humerus fracture on like after they're taking a med, and I'm like, oh, it's probably this drug. You know what I mean? Like they ask every single possible thing about these diabetic drugs.
Why is that though? Like, why do you get extremity?
I have no idea. I even tried looking it up to put a little, like looking it up why you get fluid retention, edema, extremity fractures. People are like, we have no idea. It's just like, that's what happens. The same thing for statins. Statins sometimes cause myopathy, like pain with muscles. And that's why people don't like taking them because they feel really weak because they're just sore all the time. They have absolutely no idea why. I actually went to a talk in the grad school. There's a guy that the school flew in from Stanford who works on statins. He literally works on statins, and he thinks he's starting to discover why people get myopathy with statins. And he's like, it tends to be females. And he's like, this is what I think just from doing all my research. And I'm like, this is really cool. But at the end of the day, he's still like, yeah, I have absolutely I still have no idea. So it's like one of those things. It's like, oh, like they don't know. It's just like, this is something that happens when you're on this drug, which is crazy to me that they don't know. But another thing too is these guys take a really long time to start working. So it's like don't be alarmed if it's like you give this drug and then it's like, oh, nothing really happened until about 2 to 3 weeks later. That's just like another clue that it's this drug. All right, sulfonylureas. So we're gonna start with the second generation sulfonylureas. So the drug names here are glyburide, glimepiride, and glipizide. Um, I think the sketchy for this one was how I remembered it. The little swan. I think that's these guys, I believe. And I just remembered like gliding along a lake. I don't remember. But know these names. These are your sulfonylureas. And these guys work, the primary way that these work is they increase insulin secretion. So this is why we talked about, remember, you want to close the potassium channels. Don't get got. They're going to give you options with open. They're going to give you all sorts of things. It's closing the potassium channels. That's how you trigger basically insulin release. Okay. And since we're causing the release of endogenous insulin, you will also see C-peptide. Another thing to mention is these are sulfonylureas. They're sulfa drugs. So these are sulfa drugs. So you cannot give this to a patient with a sulfa allergy. Okay, and I put this here, sulfa drugs, because again, they will throw that in there sometimes in vignettes. Patient has a sulfa allergy, and you're like, okay. Weird things with this one, hypoglycemia can be a side effect because again, you're triggering more insulin to be released, so it can potentially cause hypoglycemia and also weight gain because it's anabolism, right? Insulin's anabolism, we're causing anabolism. All right, your meglitinides, these are your glins. So repaglinide, nataglinide. These are basically meglitinides. Like I almost put them together because like sulfa drugs and meglitinides are the exact same thing. It's just like your meglitinides are your sulfonylureas without being sulfa drugs. So everything's the same. So everything this slide is exactly the same as the last slide. It's just now these just don't have the sulfa that people are allergic to in them. It's kind of like, remember with loop diuretics, if you have like furosemide is a sulfa drug. It's like, oh, you give this drug, which is also a loop diuretic, if the patient has a sulfa allergy. It's kind of the same idea. You give sulfonylureas unless the patient has a sulfa allergy, then you give a meglitinide. All right. So your GLP-1 agonists. So these are your exenatide and your liraglutide. I think these are the ones from the sketchies. These are my favorite sketchies, by the way, the type 2 diabetic drugs. I don't know why. I just thought they were so good with the Tide Pods. I'm pretty sure they're like the Tide Pods with these. And what this is going to do is it's basically going to activate GLP-1. And GLP-1, oh, I said glucose earlier, it's glucagon. I apologize. So it activates glucagon-like peptide 1, basically, so GLP-1. And basically what it does is it's really annoying. This is what I'm saying. I think of it as like it acts like glucose because it does the opposite of like what you would expect. So if you have a lot of glucose, you would cause decrease of glucagon, right? Because of negative feedback. So when you get GLP-1 being released, you have decreased glucagon. Does that make sense? I know I explained that really weirdly. So, like, that's why I get confused and I call this glucose-like peptide sometimes because I think of it as acting like glucose because when it gets released, glucagon goes down. So you kind of get like this negative feedback on glucagon. And I think if you think of it like glucagon-like peptide, I'm like, okay, well then there's tons of glucagon being released, and that's not what's happening. It decreases glucagon release.
Oh, that's so weird that it's called
Yes.
that.
Well, that's why I think that's why when I was like, oh, it's glucose like peptide, because I'm like, it's literally what glucose does. It just acts like glucose. It stops the release of glucagon, basically. It's like negative feedback. But I think it's because technically it's like the receptor for GLP-1. So it's like it's the receptor for it. So it's like when glucagon is out there, it like grabs it up. It grabs it up because it's the receptor for it.
So what it's doing, so if it does less glucagon, then there's less glucose. So it's trying to take in the glucose.
Exactly. Yes,
Okay.
exactly. And it's kind of like that's what it's saying. It's increasing glucose-induced insulin release. So like remember on like the pancreatic bit, what glucose receptor? Sorry, I'm gonna put you on blast again. Which glucose receptor is on the pancreatic beta islet cells?
Glute 4.
No, the beta
What?
islet cells. Homegirl.
Glute 2?
Yes,
Glute
very
2?
good. Amazing.
Okay.
Amazing. Yeah, so GLUT2. So this is basically acting on GLUT2, like to cause glucose to go into, like it's just upregulating basically glucose going through GLUT2 to cause now more insulin release.
Wait, so glute 2 is pancreas.
Yes.
And then what is liver again?
Livers 1 and 5, I believe.
I
Hold on.
always get this
I didn't
question wrong.
study.
Like,
I didn't
even,
study. Oh
okay.
man, no, it is GLUT2. You're right.
Wait, which one? Oh, okay,
GLUT2.
yeah. I always get this mixed up. The liver
Yeah,
and the pancreas are not glute 4.
they're not. GLUT4 is only your adipocytes and your skeletal muscle.
Okay.
Hey, I still get it confused, but I'm like, I definitely know it's GLUT2 because that's what GLP-1 is kind of trying to do. It's trying to basically activate those oh, I skipped the first generations. We'll come back to that. But it basically increases glucose to go into the cells to trigger more insulin being released.
Thanks.
But just don't get confused because it decreases glucagon. And I feel like people always forget that it decreases glucagon, even though it's kind of like a GLP. The G is for glucagon. It's just like, I think of it as a good glucose. Because, like, basically what it's doing is it's causing more glucose to go into cells and also stop the amount of glucagon being released. It's just weird. But this is like its effect of what it's doing. Like these are what these GLP-1 agonists are doing is it's increasing glucose-induced insulin secretion by causing more glucose to go through those GLUT2 receptors. So the weird ones for this one, and this is one I actually also got a question on. Of course, I got every single question on this. You give a patient a drug, and now they have elevated amylase lipase. They have epigastric pain that radiates to the back. What drug was it? And you're like, okay, they were describing pancreatitis, and it was probably one of these GLP-1 agonists.
I always get mixed up between like where pain radiates. Like gallbladder is like radiates to scapula, right? And like
Yeah, right
pancreas.
shoulder.
Okay.
So
Is there like a
gallbladder,
reason?
the gallbladder, the reason it does that, you know what's really interesting is the gallbladder is actually innervated by the phrenic nerve, by part of the phrenic nerve. So the gallbladder is innervated by its own, sympathetic, parasympathetic, but there's somatic innervation from the phrenic nerve that innervates the gallbladder. So if you have gallbladder irritation, it actually goes back to like C3 to C5 and the area of skin that C3 to C5 innervates, and it's like, or C3 to C5, and it's like the right shoulder. Isn't that interesting? So it's
Yeah.
actually the phrenic nerve. But the pancreas, it's just retroperitoneal. Like just the head of it is retroperitoneal. So if you have pain there, you're going to feel it in your back. Sad puckers. So just remember your sad pucker mnemonics for the radiation. And then this causes satiety and weight loss. So again, people like that. They're like, cool, like love losing weight on a drug. But what's cool about this one is there's no hypoglycemia risk. And again, sometimes they can ask that. They're like, you want to give a drug that has no hypoglycemia risk, which one would you give? And it would be like, this would be a good like contender to give one of these GLP-1 agonists. I want to go back to the first generation ones. I skipped right over those. I was like, oh yeah, second generation. I was like, maybe the first generations are later. I mean, they act the same. So they really act the same. The main difference between the two is your first generation sulfonylureas, you have to administer in high doses. So tolbutamide, chlorpropamide, these are your first gen sulfonylureas. You have to give them in high doses. Your second gens, you don't. You do not have to administer in high doses. And then the other thing is, again, another question I've gotten before, of course, is so they'll mention patient has type 2 diabetes, blah, blah, blah. They're on a drug that now, when they drank alcohol, they went out with their friends and drank alcohol. And now they're having this disulfiram-like reaction. They get the facial flushing, like that whole thing. Remember disulfiram? They got all that stuff happening. And it's like, what drug are they on? And they are on a first generation sulfonylurea. And how people remember that is first gen disulfiram. They just remember that in both words. And this is something you'll see too. When you get to like the psych drugs, they can go up to like fourth generation. which is, I'm telling you, psych drugs are something else. But what you'll notice is each generation, it gets like better and better. So this is another instance. It's like your first generations, you have to give them in high doses, and they also cause like this disulfiram like reaction. You give a second generation, you don't have that weird disulfiram reaction, and you don't have to give in high doses. So it's kind of like it gets better, and you'll see that too with the psych drugs. It like gets better as you go more and more generations. But those are the names of it. Okay. Next, your DPP-4 inhibitors. So DPP-4, these are your GLPs. So we've covered glins and we've covered glits. So your rosiglitinones and then your meglitinides. Those are your glits and your glins. Now we have our GLPs. These are our DPP-4 inhibitors. So these are the ones that GLP in the name. So linagliptin, saxagliptin, sitagliptin. And what do? They inhibit DPP-4. Normally, and this is like, this might help to draw it out, but normally DPP-4, so I'll just call it D, it blocks GLP-1. So here's GLP-1. So it blocks it. So normally it blocks it. And remember, GLP-1 increases glucose-induced insulin secretion. So it's good. It's causing glucose to go into cells and stimulate the release of more insulin. But now imagine we have something called DPP-4 that just blocks it. It's like, nope, can't do it. Now we have a drug that blocks it. So then we'll have normal levels of GLP-1. So it's kind of like giving a GLP-1 agonist without giving a GLP-1 agonist. Maybe the doctor's really worried about pancreatitis. Maybe they have like a pancreatic issue or something like that. You might want to give a DPP-4 inhibitor. Both of them are going to, so they work the exact same way, honestly. Like even the mechanism is exactly the same. Both of them are going to decrease gastric emptying. So if you notice, both of them cause satiety because it's like they decrease the gastric juices basically releasing. So it makes people feel very full, which is again not adverse because it makes them not want to eat as much and then they lose weight. Okay. But the weird one with this one, and these are the weird side effects that they'll ask about, is a lot of UTIs with this one for some reason, and a lot of like sinus infections with this one. Okay, so this one, you have no pancreas issues, but you have a lot of sinus and like infections like that. This one, no sinus and UTI issues, but you have pancreatitis. No hypoglycemia risk with this one, so this would also be like another contender for which of the following would you give if you're not worried about hypoglycemia. All right. Getting to the end, I promise. So next is your islet amyloid polypeptide. So how people remember this, it's called pramlintide, and people remember that by amylin. So it's kind of like it's in the name, sorta. So amylin, pramlintide. It's basically just like amylin that you're giving. And what amylin does is it basically stops glucagon from getting released. And again, remember, glucagon and insulin are exact opposites. So if glucagon goes down, insulin will go up just by nature of the body. So what this is good for is this is really good for hyperglycemia control in your type 2 diabetics, especially after they have a meal. So it's kind of like your short-acting insulins, but for your type 2 diabetic. It's good to give after a meal just to make sure like there's good regulation of insulin, basically. So adverse effects of this, hypoglycemia, obviously nausea and weight loss. And it's because you have this decreased gastric emptying, you're going to have satiety and therefore weight loss. Okay. And then finally, there's two more, but your SGLT2 inhibitors, this is the one that everyone says, my friends all think of SGL, like the other curriculum, and they just like, I don't know, but yeah. So SGLT2 inhibitors, remember SGLT2 is in the kidney, and it's what basically allows for it's like the double, oh my God, the uptake of both sodium and glucose. That's that guy. So these are your glyphs. So we've covered glits, glins, GLPs, and now our glyphs. So canagliflozin, dapagliflozin, oh my God, and empagliflozin. These are your glyphs. These work by decreasing glucose absorption. So they just block glucose absorption because they just block SGLT2. So you're not getting glucose reabsorption in the PCT. Usually you don't give this as the primary drug ever. It's, if anything, you give it in addition to like metformin or one of those other ones we've talked about. This one, think of this primarily as being like an osmotic diuretic in a way because you're blocking glucose reabsorption in the PCT, glucose is very osmotically active. It's kind of like mannitol, right? Like if you give a mannitol diuretic, so it'll just kind of go through the entire urinary tract, like the entire nephron, I'm sorry, the entire nephron, and it's going to keep water. It's just going to keep water. So it can lead to basically this osmotic diuresis effect where you get dehydration, you can get orthostatic hypotension, hyperkalemia, and then weight loss. Because again, diuretics, you tend to lose weight because you're losing water. And then the other thing to remember with these guys is you're keeping glucose basically in the urinary tract. What likes glucose? Bacteria. So you get and yeast. So you get tons of UTIs and tons of yeast infections. I didn't highlight UTI because remember these guys can also cause UTIs. But I will say if you're in a question and they talk about UTIs, I would tend to think of an SGLT2 inhibitor before I think about one of these guys, this DPP4s. But that's just me. And then again, since this is acting on the kidney, it's a relative contraindication for someone that has renal insufficiency. Okay, just like anything that works on the kidney. And then the last guy, your alpha glucosidase inhibitors. Acarbose, miglitol, these are just those guys. These are going to block the brush border alpha glucosidases in the small intestine. So now we're in the small intestine, which causes delayed hydrolysis. Basically, it's not allowing disaccharides to get converted to monosaccharides. And remember, we can only reabsorb monosaccharides, right? So it's basically blocking that process by blocking these alpha glucosidases. So it's the same as like your SGLT2s. It's like you kind of add it on. You can give it for a type 2 diabetic after they have a meal or something. But the side effects for this one, and this is why people really don't like it, since it acts in the small intestine, it can cause diarrhea, flatulence, and abdominal pain. This was my question about these guys. Is there someone that had tons of flatulence after taking a drug for their type 2 diabetes and is an alpha glucosidase inhibitor? And this I just probably forgot to erase from the last slide. There's nothing wrong with the kidneys here. This is in the small intestine. Okay, those are the glucose meds. How are we feeling?
Good. That was helpful. I think I'm gonna go back because I always forget the names, you know?
Yes, and that's what I'm saying with Pharm. A lot of the times what makes Pharm tricky is you have to like you see miglitol and you just automatically have to think, "Oh, that's an alpha glucosidase inhibitor." And that is, again, what makes your psych Pharm so difficult is because what's the one with like a million names? This one. There's like, for psych Pharm, it's like there will be like 4 drug names that all fall under one category. And every single category has like 4 to 5 drugs. And you're just like, oh my God. And honestly, that's why I say like Anki, some sort of spaced repetition is so good for that because it's like just the more you see it, the more you're going to be like, oh yeah, that is that type of drug or that is that category of drug. Okay. All right. So lipid lowering meds, we're going to go through the metabolism very quickly, and then the drugs are not going to take as long, I promise. I want to just spend a little bit more time with the lipid metabolism because I really think that this is very, very high yield. But I broke it down a little bit because I just think this is extremely just a lot. But I put this at the end as well because I like that it gives you all where all these drugs work in this pathway. And that's pretty much what these drugs are doing is they're trying to like act on a stage within this lipid metabolism pathway. So remember lipid metabolism, there's 2 pathways. There's exogenous and endogenous. And your exogenous pathway, this is like what you're eating. So this is like your dietary fat. So this is your ingested lipid sources. And then they go through this process. Eventually it's going to get back to the liver and that's your dietary cholesterol. So we're going to talk about that first. So here is your small intestine. And here's the pancreas, here's the ampulla of vata right here, your bile duct goes in there. All right, let's say you have a very fatty meal. Here it comes. CCK gets released, right? Because CCK loves those fatty meals. And it's going to cause your gallbladder to contract. It's going to cause it's going to get bile acids being released. It's going to cause your, the sphincter to open, basically, the sphincter of Oddi. Various pancreatic enzymes kind of come and kind of like help digest this. And then basically, at the end of the day, we break this very fatty food down into monoglycerides, free fatty acids, cholesterol, your fat-soluble vitamins, and then they're surrounded by bile acids, right? And this is what's known as emulsification, where it's like the bile acids are surrounding all these things. So you can think of this as being a mixed micelle. Mixed micelles are, again, you can think of the bile acids on the outside, super, super hydrophilic. And then on the inside, it's very hydrophobic, very fatty. So this is actually water soluble. And the reason that's important is because it can basically go now to like the brush border enzymes. It can be uptaken by these brush border enterocytes within the small intestine and further sent along into the body. They can go into the blood. So now here's the mixed micelle, and then when it gets into one of these enterocytes, the first thing that's going to happen is you're going to get bile acid recycling, right? That's in your ileum. And the other thing that's going to happen is you're going to get further breakdown of this. You're going to get triglycerides, free fatty acids, cholesterol, cholesterol esters. The rough ER within these enterocytes releases ApoB48. All these APOs come back. ApoB48 is going to combine with this combination of stuff that we broke down, and this is what your chylomicron is. Right? All kind of ringing a bell. So your chylomicron is going to be tagged with ApoB48, and it's going to be mostly made up of triglycerides, but there's other stuff in there. And that's why it's so big and so fatty, is because there's just tons of triglycerides in there. So here's my chylomicron. Now it's going to leave through a lacteal, which is a lymph vessel, and then it's going to go to the blood. All right, now we're in the blood. And now once we're in the blood, what's going to happen is your chylomicron is going to be acted on by HDL. And remember, HDL has ApoC2 on its surface, as well as ApoE. Okay, and what it's going to do, it's basically going to send these two to go to the chylomicron and just basically remove some of those. Well, it's going to bind to it. So now we have C2 and E present here. And then when the chylomicron is moving through, so you saw what happened. HDL gives it C2 and E. It's moving, and then what does it come into contact with? Lipoprotein lipase, LPL. And keep all these enzymes in mind, because the lipid-lowering agents act on some of these enzymes, right? That's why we're going through this process. But what LPL does is it takes, and the reason why it was very important for it to take this C2 from HDL is because lipoprotein lipase will not work if C2 is not there. It absolutely needs ApoC2. So ApoC2 binds to lipoprotein lipase, and then what lipoprotein lipase does is it breaks down free fatty acids from those triglycerides, and it gives it to adipocytes, and it gives it to skeletal muscle. Right? So now we're left with chylomicron remnants, and we know they're remnants because they have the ApoE present on its surface. All right. So now from here, we have our chylomicron remnants, which have B48 and E on its surface. It goes to the liver. Now the liver, in order to uptake this, it needs ApoE. So LPL needed C2, the liver needs E. All right, and then it uptakes it, and now we have our dietary cholesterol. I can use it for cholesterol. So here's the summary, everything we just said. All right, so that was exogenous. Next is endogenous, and endogenous is a little bit different because now that's where we start getting LDL, VLDL, we start getting that stuff. So only the liver synthesizes cholesterol. Hopefully we know that. 80% of your plasma cholesterol comes from the liver. Only about 20% comes from what you eat. So if you hear that someone says that they have high cholesterol because they have a really bad diet, you're like, probably not. And that's also why you can have someone that is very healthy and like eats really well. They can still have high cholesterol because it's just like it's like a genetic thing. But yeah, so that's the first thing that happens in the liver is cholesterol synthesis. And you also have lipoprotein synthesis in the liver as well. So VLDL, HDL, LDL, well, LDL, IDL, they all come from VLDL. But the liver, if it asks like what lipoproteins are synthesized in the liver, VLDL and HDL. Because if you notice too on here, those are the only ones that the liver is like specifically secreting. All right. So the first thing is cholesterol synthesis. You really don't need to know this whole process. I would just basically know that you go from HMG-CoA to mevalonate, and HMG-CoA reductase is the enzyme that does this. What drug blocks this enzyme?
Is it statins?
It is. Oops. Oh, I thought I had it on here. Yes, this is your statins. So this is what your statins do right here. So your statins just endogenously decrease the amount of cholesterol being made. That's why it's such a good drug, because it's like, it has nothing to do with your diet at all. It's like, it's just what the liver makes at a baseline. It's decreasing that amount. Again, that's why it's such a good drug. But sometimes I've seen it won't, like, they know that everyone knows it's HMG-CoA reductase. So sometimes what they'll say is like, what step in the process do statins block? And it's like, oh, from HMG-CoA to mevalonate or something like that. Okay. And then once you get your cholesterol, after all the various steps, your cholesterol gets packaged in VLDL, and then the liver sends out VLDL. It's like, here you go. So it sends out VLDL and it sends out HDL. HDL, remember, is going to have your C2 on it, your ApoE, and then A1. A1 is just like the marker for HDL. Because remember, HDL can give other things, C2 and E, like we just saw with the chylomicron, right? Down here, your VLDL is everything we just talked about. That cholesterol gets packaged into a thing, and then it has B100 on its surface, so ApoB100. Again, marker for your VLDL. So what does HDL do? HDL is a scavenger. It's really good. That's why it's good to have very high HDL, because it scavenges. It kind of goes and finds cholesterol and brings it back to the liver. And it doesn't allow for plaques to form, really. So that's why people say, like, the higher HDL you have, the more cardioprotective you are from having, like, a heart attack, basically, because it's like it's basically trying to stop plaques from even forming, and that's kind of what causes heart attacks. There's these two enzymes to know, LCAT and CETP, which we'll talk about, we'll talk about now. So basically what happens is the liver releases this very, very, very large HDL. It's super large. It's going to activate this enzyme called LCAT, so LCAT, and then it's going to break down some of these cholesterol particles to cholesterol esters. So it kind of makes it a little bit smaller. It makes it really small because now we don't have giant cholesterol. We have cholesterol esters, which are just smaller. And then from here, we have the small HDL. Next, we have your VLDL. It can work back and forth with the CETP enzyme. And basically what's happening is it's grabbing some esters from HDL, and it's like swapping the triglycerides and the cholesterol esters is what the CETP enzyme does. It takes some of these small cholesterol esters from the HDL and giving it to your VLDL. And then it's taking some of these triglycerides from the VLDL and giving it to HDL. And then it's saying like, hey, HDL, go back to the liver. Like, go bring that back to the liver. Okay? So that's what those enzymes are doing. So here you go. Here's your C2 and your E. And then it's like, oh, I already had that. Goes back to the liver. So from here, what does VLDL do? So VLDL is basically going to pick up C2 and E from HDL, and then it's going to go find lipoprotein lipase, and then LPL removes more of those triglycerides. CETP also removes some of those triglycerides, and at the end of the day, when we're removing some of these triglycerides, we're creating IDL, intermediate density lipoprotein, right? So here's that process. Here's VLDL. It picks up C2 and E from HDL. Now it goes to find lipoprotein lipase, which requires C2. And then you get basically breakdown of those triglycerides into free fatty acids that the fat tissue and the skeletal muscle can uptake. And then that whole process from before where CETP can take some of the triglycerides and give it to HDL, and they can just basically swap the cholesterol esters for it. From here, your HDL can go back to the liver, can be like, hey, like, look what I found. Like, I have all this cholesterol for you. And then the VLDL is now a little bit smaller because now it doesn't have as many triglycerides as it has before. So both of these processes make IDL. Okay, so now we have IDL. Here's IDL. Guess what happens next? It gives away C2 and E. It's like, here you go. I don't need this anymore. So it gives C2 and E back to HDL. Because remember, HDL is just everywhere. It's like everywhere. So it's like if these things don't need it, they just give back C2 and E to HDL. It's like, here, I don't need it right now. Now the IDL undergoes another enzyme called hepatic lipase, and it's going to basically take more of the triglycerides away, and then now we're going to have LDL. So this is how we have LDL, and this is why on LDL we only have the B100 marker, and we no longer have C2 and E because IDL gave it back to HDL. Following me? And I only really harp on this because a lot of the times they will not tell you something is LDL. They'll say this is something that has B100 on its surface, or something that has, I don't know, C2 and E on its surface, and A1. And you have to know, like, oh, that's HDL, that's LDL, blah, blah, blah. All right. So now LDL, very, very low triglyceride content, because now we went through the CETP enzyme, we went through LPL, we went through hepatic lipase. Like, we went through so many lipases. So we have very, very low triglycerides present. And just because of that, it just seems like there's more cholesterol and cholesterol ester content. And now its whole job is to bring cholesterol to any cell that has an LDL receptor on it. Okay. And this is also what we're going to talk about because there's another drug that triggers LDL receptors to be present. And you can think of this as like cells that have more LDL receptors on its surface can uptake more LDL and remove it out of the blood. So you can imagine like a job of something that would cause more LDL receptors to be like why you would give a patient this drug that increases the amount of LDL receptors on cell surfaces is because this patient has a lot of LDL in its blood and you want to try and remove some of it. Okay. So here is LDL. It has its ApoB100 on its surface. It binds to its LDL receptor. LDL takes it in and then it just breaks it down basically. And then it digests everything and then it releases cholesterol. If this is in the liver, now the liver can use this. It's like kind of like it can recycle that cholesterol instead of making more cholesterol. So here's a summary, everything we've talked about. But what I kind of wanted to show you here is, is kind of like the liver itself can have LDL receptors on it. So let's say we get to the part where we have LDL, it can bind to the receptor and then it uptakes it and then it doesn't need to make cholesterol, it just uses what was recycled. That was everything here on this side. Here's my little chart that I made. So again, like I said, sometimes they don't say, oh, we have a chylomicron. They'll just say we have this thing present with B48, C2, and E present on its surface. I have what it was made by, what its primary content is, and then what its role is within this process. Something interesting are chylomicrons are only present after meals, and they make your blood look kind of fatty, because again, it's dietary, right? It's dietary. This is actually why you have to fast before you get like a lipid panel. This is actually the primary reason. Like it has nothing to do with cholesterol and LDL. It's just because of the chylomicrons. It'll make the blood look really weird if you don't fast before you do a panel like that. All right. So with all of that, now with these lipid lowering agents, they're going to be acting on something that we just talked about in that pathway. Okay. So we have our statins. These are first line. Everything else is considered second line, everything else. So you always, always, always give a statin, again, unless there's some sort of contraindication for why I would not give a statin. You can also add on to drugs as well. It's kind of like with the diabetic drugs, you can give two, you can add on to statins, you can give like a fibrate and like a cholesterol binding resin or something. I'll talk about ones that you can't combine, and that's usually a question. But you know, people that are on fish oils and like certain vitamins. So it's like you can stack these and it's fine. So statins, it's kind of like the metformin slide. It's just like there's a lot of stuff to know about statins. It's because it's the most commonly given drug. So these are the ones that have statin in the name, which is really cool. All statins have statin in the name. So simvastatin, atorvastatin, rosuvastatin, and prazostatin. So they all have statin in the name. They inhibit HMG-CoA reductase, so they block that enzyme. So remember, you're blocking conversion from HMG-CoA to mevalonate. So if you don't have mevalonate, you can't make cholesterol, and then you're basically disrupting endogenous cholesterol production. This is actually what the guy was talking about like how statins work. At the talk I went to, he said like this is like new, like they just kind of discovered like within the past few years that statins can actually increase the amount of LDL receptors that are on the surface, which is cool. So in addition to blocking HMG-CoA reductase, they can also put more LDL receptors on the surface, which again, statins are just very good. They're just very good drugs. So these are your first line for hypercholesterolemia, very, very good at lowering LDL. It also increases HDL and lowers triglycerides. So it's like everything you would want in a drug, a statin does. It increases HDL and then it lowers everything else. Adverse effects, myopathy. This is by far, like if you see myopathy as a side effect, they're probably talking about a statin. You cannot give statins to patients on vitamin B3. No, what's niacin? Niacin's B3? Forget. We'll talk about it. So don't worry about it. But if a patient is on that vitamin, if they're on niacin, you can't give them because it increases the chance of having myopathy, as well as a fibrate. That was my question. It was like a patient was on a statin, and then they said, oh, the doctor added a second drug, and then all of a sudden there's myopathy. And it was like, what drug was it? And it was one of the fibrates. And again, that's how they're going to word these questions. It's going to be like side effects after they add a drug, take away a drug. Like, that's like what they're going to do rather than like, what drug would I give this patient? Something interesting too is like, the myopathy is causing muscle breakdown because you have elevated CK levels in the blood. Like literally, remember, CK is creatine kinase. It's only there when muscle gets broken down. So just something weird happens with statins. You can also have hepatotoxicity, so you can have elevated LFTs. Again, don't know why. It's just like something that can happen. It's probably because it's like acting in the liver, so it's more likely to cause like a weird, hepatitis-like reaction. But the note here is that this is one of those drugs that decreases mortality in patients with coronary artery disease, and it is the most effective drug at lowering your LDL cholesterol. Okay. Sometimes I'll even ask that. Remember, like, when you guys are doing like heart attack stuff, like heart failure stuff, it's like, what drug do you absolutely have to give the patient? And so you have to give them like either an ACE inhibitor, an angiotensin receptor blocker, or a beta blocker. You have to give them one of those drugs because that will decrease cardiac remodeling. Kind of the same thing here. It's like if a patient has coronary artery disease, you have to give them a statin because it's like has been shown to decrease mortality. And not many drugs have been shown to decrease mortality. That's why it's like, it's really interesting to like, whenever they say that, it's like, oh, like that, they might ask about that kind of thing. Your bile acid binding resins, we kind of talked about these very briefly a little bit ago, but it's just the names. You just kind of have to know that these are the names for these drugs. So cholestyramine, cholestyramine, and cholesevelam. This is probably the most common one, cholestyramine. And what these basically do is they bind bile acids. So it's going to bind bile acids and stop their recycling to the liver. And the whole idea of this is to promote new synthesis of bile acids. So it's like, let's increase the amount of bile acids being here because then we can probably break down more things. And you would give this in conjunction with statins. It kind of just probably helps. But we did talk about a lot of these adverse effects. We talked about how it can cause cholesterol gallstones. It causes an inability to reabsorb fat-soluble vitamins because, again, remember, the bile acids in the ileum, when you reabsorb it, that's what allows for the reabsorption of those fat-soluble vitamins. So now you're blocking that process. So you can have any of these deficiencies, which, again, each one is so different. And that's what we were kind of talking about earlier is like, oh, like this patient with acromegaly can have like this hyperprolactinemia kind of instance because that's just like something that can happen. Same thing here. It's like you put a patient on cholestyramine, they might have a cholesterol gallstone, but they also might start bleeding randomly because they have a vitamin K deficiency, or they might start having night blindness because of their vitamin A deficiency, or rickets with their vitamin D deficiency and whatnot. So it's just something to keep an eye out for in these types of questions. And that's why it's good to know, like, what do bile acids normally do? And then what would happen if I bind it and don't let it do what it normally does? Okay. So that's those. Your cholesterol binding resins. The only one pretty much is ezetimibe. So we love when there's only one. So this is your cholesterol binding resins. It's basically going to block intestinal absorption of cholesterol in the small intestine. So what this is basically saying is it's not allowing you to reabsorb cholesterol. So it's like you're blocking exogenous reabsorption of cholesterol. Okay, so it's like pretty much you're taking away, so statins take away endogenous cholesterol, your cholesterol binding resins take away exogenous cholesterol. Okay, so you're trying to limit cholesterol on like by blocking it on one of those two pathways. Again, give it in conjunction, it's a second line. And then you can also, again, since it has something to do with cholesterol, it can have this weird increase in LFTs, but it's very rare. All the side effects for these are kind of rare.
So endogenous, you mean that it's like preventing the making of it?
Mm-hmm. Exactly, and that's what statins do. They block the, and remember, 80% of cholesterol in the blood comes from making it, versus this one would be only 20% would come from like the exogenous cholesterol.
So it probably doesn't have that much of an impact then.
Right. It probably doesn't. And that's why it's like you can give this in conjunction to another medication. But yeah, you probably wouldn't give this on its own, like at all. Okay. Oh yeah, so PCSK9, we didn't really go into PCSK9 in that process, so I just put in like a few extra slides what PCSK9 does. So here's my cell membrane. I just love using PowerPoint. Can you tell? I just love PowerPoint. But so here's my cell membrane, my lipid bilayer. Here are my LDL receptors. So like, let's say we're in the liver. Oh, we are in the liver. So we're in the liver. This is the liver. Remember, the liver has LDL receptors on its surface. And like here's out here in the blood, this is where normal LDL is. And here is PCSK9. It's found basically in these vesicles within like the membrane of, whatever cell has LDL receptors. It's just present there. So what PCSK9 does normally, like this is just PCSK9's normal physiologic function. It's going to, when an LDL binds to an LDL receptor, PCSK9 gets secreted, binds to it, and then it basically tags it for destruction. It's like, nope, we are going to destroy you. Because remember, normally the LDL receptors can get recycled. So it's like it brings in LDL and then the LDL gets broken down into cholesterol, but then the receptor gets recycled. So on what slide was it? This slide. So here's like the LDL receptor in blue. It gets recycled back to the membrane while the LDL gets broken down. PCSK9 is like, no, we're not going to let you get recycled. So it's basically like tagging an LDL receptor to get destroyed. So normally PCSK9 decreases surface concentration of your LDL receptors. Okay, so that's what it does normally. So how does a PCSK9 blocker work? It's an antibody. It's a monoclonal antibody, and it's specifically trying to block PCSK9. So now LDL binds to its LDL receptor, it gets come in, and then here is your monoclonal antibody. It's like, nope, because it gets secreted into the blood, right? PCSK9 gets secreted into the blood, and then it binds to the receptor. So someone super smart was like, oh, we can target that with a monoclonal antibody if it's in the blood. So you take this drug, it blocks PCSK9 normally, and then boom, now we have, normal breakdown, but then we get that LDL recycling, which is cool. So since we are increasing the surface concentration of the LDL receptor, we're removing more LDL from the plasma and putting it more into because the more receptors you have, the better, right? So this can actually decrease your risk of cardiovascular disease, which is really cool. So the name for these guys are alirocumab and evolocumab, and it's pretty much the only lipid-lowering agents that are monoclonal antibodies. Remember these from, hem-onc? And that's why they're monoclonal antibodies to PCSK9.
Where are the LDL receptors located? Like on what organs?
Like a lot of organs. So a lot of the times it's like your adipocytes and your skeletal muscle. The liver has tons, but normally your cells do have LDL receptors on them because they do want to uptake LDL to use it as like, a potential energy source if there's not enough glucose or whatever. So all cells pretty much have LDL receptors, but I would say like for the most part, like they're highly concentrated in the liver. Highly, highly concentrated. Okay. And we talked about this. The not great things about your like evolocumab, for example, is they can cause delirium and dementia and like neurocognitive effects, which is not great. So it's like, imagine like they give you a prompt and then it's like, oh, now all of a sudden the patient has dementia. You're like, what? It's like for their LDL, like they have dementia. You're like, all right, that's probably like an anti-PCSK9. Like that's a monoclonal antibody.
I wonder if you stop taking it if it goes away or if it's just like downhill from
Interesting.
there.
That's interesting. I have no idea because I don't even think they know why you get dementia and delirium from it. I mean, I'm sure I can probably look into that. I don't know why. That's interesting though. But yeah, it's like this is like that's like the weird side effects with these guys is you have like neurocognitive side effects with your PCSK9 inhibitors and it's like, "Oh, okay. Like that's very unique. Okay. A couple more. So these are your fibrates. These have fiber in the name, which is nice. Fenofibrate has fibrate in the name, which is nice. But look for that. Those are your fibrates. These, I would highly suggest knowing both of these mechanisms. Again, I know it's like I keep saying that, but I have gotten questions on these before. So one thing that it does is they upregulate LPL. And you can already imagine if you upregulate LPL, you're just hydrolyzing the heck out of anything that comes its way and you're lowering the triglyceride content, right? Because that's what LPL does. It hydrolyzes triglycerides into those free fatty acids and then it gives it to your adipocytes and your skeletal muscle.
So a lot of these drugs, they probably make you like gain weight, right?
A lot of these drugs make you gain weight, yeah. Unfortunately, unless it's a statin, because then you get breakdown of your muscles, which is really strange. But yeah, a lot of these unfortunately do make you gain weight. But honestly, you probably are already a little bit, if you're on one of these drugs, you probably are already a little bit heavier. So it
True.
might actually just like level, you might not even notice. Um, but this one is like classic question. Like which drug would I give to lower triglycerides specifically? Not LDL, not VLDL. It's like I want to lower triglycerides specifically, fibrates. Another thing that they can ask is what drug do I want to give to increase HDL? And we have talked about a few of these that do increase HDL, like statins increase HDL. What were some of the other ones? Let's see. Did I not mention it? Oh, maybe it's just this one. All right, so not statins, these guys. These guys also increase HDL. They're one of the only ones that increase HDL. So, really good at lowering triglycerides as well as increase HDL. And how they do this is they activate an enzyme PPAR alpha. So, you can already imagine, remember PPAR gamma from the diabetes drugs. This is PPAR alpha. So, don't get confused. Know
Wait,
the
what
full
does the
name.
gamma one do again?
That's for your metformin. So, that's going to, that's kind of what, let's go back to it. Yes. Oh no, it's not metformin. Oh man. This one. Sorry, it's the one right after metformin. Your glits. Your glits activate PPAR gamma, which increases insulin sensitivity. But PPAR gamma is located in the muscle, fat, and liver. And notice it decreases triglyceride levels in the serum. So it's kind of just like a cool like little tie-in with these two drugs is like, oh, it's like a PPAR enzyme is doing a similar thing with these diabetes drugs as well as these lipid-lowering agents.
Is it increasing like glute transporters or like how is it increasing sensitivity?
I think it specifically is activating gene transcription. Like it's going down to like the genetic level to upregulate this enzyme adiponectin. And then adiponectin is kind of like affecting the amount of glucose that gets metabolized. It's like increasing glucose metabolism, maybe. I don't think it's specifically acting on the receptors. I think it's working through this adiponectin enzyme to go do its dirty work for it. It's like, all right, go activate the glucose receptors go activate glucose metabolism to make cells more sensitive to insulin, basically. But I don't believe it's a good question, but I don't believe it does anything with the transporters. Because I think with the transporters, you need to specifically activate gene transcription for the transporters, which is going to be that other path, like that PI3K pathway. That's what insulin does. All right, so PPAR gamma with your glits, your thia, glitta, blah blah blahs. This is PPAR alpha, and when PPAR alpha gets increased, we increase HDL. Remember these ones, you can also get cholesterol gallstones. It's the same ones as your cholestyramine. Remember cholestyramine, your bile acid binding resins, and we talked about how it can inhibit 7-alpha hydroxylase, and that's when you can get cholesterol gallstones. It's the same thing here. These can also cause cholesterol gallstones. This is one of the ones that you really shouldn't give with statins. I know I have like, oh, use it in conjunction with statins. You can, but you're gonna increase the possibility of them developing myopathy. And like I said, I think the question I had gotten before was patient was on a statin and it was like the doctor added an additional drug and now they have really bad myopathy. And I'm like, oh, it's a fibrate because it's like it's just known to like work with statins to increase myopathy. All right, two more. So we got our vitamin and we got our fish oil. So we got B3. I knew it. All right. So we have B3. This is niacin and it's literally vitamin B3. You can buy it over the counter. And this hasn't been like super proven. That's why even like even the indications, it's like you would never give this on its own. Like if a patient came in, you would never ever do it. It would always be added in addition. But what niacin does is it will inhibit lipolysis, so it blocks hormone sensitive lipase. We didn't talk about hormone sensitive lipase. I apologize. But insulin actually also acts on hormone sensitive lipase, so that's like an interesting tie-in as well. But hormone sensitive lipase is an adipose tissue. So niacin can block that, and then you're going to block the breakdown of lipids. Okay? So you're going to do that. It can also reduce the amount of VLDL that gets synthesized in the liver. and it's super good at increasing HDL. Okay. So this is kind of the one where it's like you really want to increase HDL, you would give niacin. Just remember though, your fibrates can also increase HDL. So this is what I like when you start seeing all these drug mechanisms and stuff, start looking for like the similarities between a lot of these drugs because that's what they're going to try and like trick you up on. Be like, "Oh, okay. So this one increases HDL. This one really like is really good at increasing HDL." You use it in conjunction with statins. You can also do it when you want to increase HDL levels. Like let's say patient has like an HDL of like 30 and it's like I really want to increase this patient's HDL, give them like niacin, like give them a niacin supplement. But usually when they ask about niacin, it's with the side effect. And there's two questions I always see about niacin. So it's like you give this drug to this patient, and all of a sudden there's like facial flushing. So their face just turns like bright red. They look like very hot. It's like very warm. And then it's like, how do you treat this? Like, how do you treat this flushing of the face? NSAIDs. You give NSAIDs, which I think is super interesting. Okay, so niacin causes this facial flushing as a side effect. You don't stop them on the niacin, you just give them an NSAID. It can cause hyperglycemia because, again, it's kind of messing with lipolysis. It can kind of cause lipodystrophy in a way. And I think it's just the other effects of hormone sensitive lipase. Like I said, insulin also acts on hormone sensitive lipase. So you can kind of mess with insulin's role. So you can get elevated glucose levels. Another weird thing you can see is hypouricemia. So it's like you give a patient niacin and now all of a sudden they have gout. You're like, oh, that's weird. Don't stop the medication, give them allopurinol. And then it rarely elevates LFTs. Okay. And then your fish oils. So these are your omega-3 fatty acids. You can buy these over the counter. This is actually what I work with in my lab. I love omega-3 fatty acids. We love them. But what these guys do is they decrease what they think does is this hasn't been proven. They still don't know if this completely works, but it's believed to decrease free fatty acid delivery to the liver. So basically it's saying like, okay, if you're decreasing the amount of free fatty acids that go back to the liver, you know, like the HDL scavenging, if you're decreasing that delivery, you're decreasing the development of the enzymes that make triglycerides. That's a theory. I will say anytime there's a theorized mechanism, they won't ask about it. So they probably will not ask about this. Okay, but I just wanted it wasn't first aid, and it is something that I did want to mention. The only thing I could think of is like straight up when they say like, "Oh, patient, bless you, is on this new medication, and there was a fishy taste to it." There you go. It's your fish oils, your omega-3 fatty acids. So then here's the picture again. So then now after you went through this, honestly use this picture and go through it and be like, oh, like that's where it's working. Remember the cholesterol absorption inhibitors, the ezetimibe. Remember that is blocking cholesterol from the exogenous area, right? That's like the exogenous cholesterol that it's blocking. Your bile acid like binding resins block reabsorption of bile acids before they get to the liver. So these are very exogenous drugs. And then you have your fibrates that work on LPL, your niacin, which is blocking the lipolysis via hormone sensitive lipase in the adipocytes, and then all the other guys kind of work on, you know, directly on the endogenous cholesterol or somewhere in the endogenous pathway. So your PCSK9 inhibitors, the HMG CoA reductase inhibitors are over here. And then other than that, just memorizing those names is really like all these names here. Just kind of have those memorized, and you'll be good. You'll honestly be good with these, and these are really, really high yields on exams. So it's good to know it's a flex. It honestly is a flex to like know these. And then I wanted to put another picture. This is from first aid now. I think it's kind of good to see like where are all these drugs working. So again, it's like kind of like the endogenous stuff that's happening in the blood, stuff that's happening before the liver, and then stuff that's happening like directly, you know, bile acid reabsorption in the intestine. So just to kind of help you visualize it more, if you need to kind of separate these out a little bit more. All right, there's only two questions. And again, it's more so just to show you how they would ask a question like this, okay? But do you have any questions before we dive in?
No, I just need to review it
I
again.
know.
I'm
It's a
gonna
lot of information. Can you imagine now if I was like, okay, now we're gonna do repro drugs? You'd have been like, oh my God. You'd have been like, no, I can't do repro drugs. But because but I will say these are probably the most, I'm not even kidding, the most high yield drugs on all of boards besides your psych drugs. Your psych drugs take over everything. But if I had to pick, again, if I had to pick drugs, it would be your diabetic drugs and your statins and like your lipid lowering, because those are the ones that are just so prescribed, like just all the time. Okay. All right, first one.
So it's type 2.
Okay.
So it's one of them that it's a type 2 medication.
What else though might change your answer about the patient?
Oh, they're also, oh, they're pregnant. So you would give them a type 1 drug, right?
Mm-hmm. I don't know, you tell me.
I think so. I think so.
Okay.
Um, I don't think it's A or B.
Okay.
Binding of, would it be, I think it's C or F.
Okay. So you think it's CRF. So
Oh, I think it's, well, what is, so if you open the channel, you want to close the channel, so it's not F. So is it C?
yes.
Okay.
Woo! Amazing. Very good. Yep. So, like I said, they will try. I'm telling you, don't get got on this because they will try. They will do this. They will say opening of the potassium channels, and you're like, nope, it's closing. Closing is what insulin does. But I also really like this question too, because this is the type of question you're gonna see. It's like, what's the mechanism of the most common drug for this condition? This is like, I'm not even kidding. This is every single pharm question on boards. Here's a disorder. What's the mechanism of the most common drug for this disorder? Or what's the side effect of the most common drug given for this disorder? Okay. So very good catch though. This is a pregnant woman. Pregnant women, think of them as type 1 diabetics. And
I have a
remember,
question.
yeah,
So with pregnancy, so my mom had gestational pregnancy twice, I think. And it
yeah.
made
It's,
me
honestly,
wonder.
if you have it one time, you'll probably have it for every pregnancy.
So like why do you is are there certain people that are at higher risk?
They have no idea. They really have no idea. They don't know. There's no HLA marker. It's really, and that's what's weird about it is like you have diabetes during pregnancy and then you never develop it after you give birth. It just, you never, it's like just a weird thing. My mom had gestational diabetes as well. Usually, if you have like twins, because I was a twin, usually twins have a higher risk because you have two babies. So it's kind of like the body's like, ah, I need a lot of glucose kind of thing. But they don't know. They have absolutely no idea.
Like you know how you're a twin? Does one or was one of you like really big and one of you really small?
No, no. They look for that, the twin transfusion syndrome. Yeah, they look for that. But no, I did not steal. A lot of the times twins like one eats the other in the womb, which is wild.
Really?
Yeah, it's like they want all the nutrients. So like they want everything. So they like will either eat the other one or it's like they'll take all the nutrients so that the other one dies, which
That's
is
like natural selection right
it
there.
is. It honestly is. But they do look for that. They look for like to make sure that there's no twin transfusion. There's ways to monitor how big like the fetus is and they can like kind of track that, which is cool. But yeah, this is the classic way that they're going to ask you a question. I also like this question as well because it has all the names written out. So dipeptidyl peptidase 4, this is DPP4. Peroxisome proliferator activated receptor gamma, this is PPAR gamma. And this would be the same for PPAR alpha for, you know, the lipid ones. Okay, so, and then SGLT2, sodium glucose transporter 2. And yeah, they have all the names written out, which is good to review that. All right, awesome. And then here's this, here's your insulin, your alpha sheet, your beta sheet, your disulfide bonds, blah, blah, blah. And then it kind of goes through this whole pathway as we talked about. But it is a tyrosine kinase receptor, dimerizes, and then it phosphorylates itself, and then it dimerizes and blah, blah, blah. Okay, all right. And then the next one.
2 weeks after being hospitalized. So pancreatitis was keyword for one of them, I remember,
Mm-hmm.
right?
Yeah.
So, so they're asking about the mechanism of
Yes.
fibrosis.
So this one they actually told you, which was nice. And so I was like, oh yeah, pancreatitis, but I'm like, it doesn't really matter.
So cross out B.
Okay, good.
Um, inhibition. I don't. Okay. Um, I don't think it's D.
Okay.
Um, regulation. I don't think it's F.
Okay.
Um, reduction. I think that maybe it's A or C.
So do you remember the only one we talked about that reduces the LDL receptors that get degraded?
Is that the one that starts with an E?
Yes. Remember the PCSK9 inhibitors? That's the one that physically stops degradation of your LDL receptors.
Oh, yeah, okay.
Think back about fibrates. You can do it.
Is it C or E?
So, yes, it was E. I wasn't gonna do that for too long, but yes, it is. Oh, I didn't cross off F for you. I'm sorry. It is E. Um, it just that's what fibrates. So again, it's kind of like they'll tell you the drug or they'll give you like they'll say like a drug was initiated, here's a side effect, what drug like what's the mechanism of the drug, blah blah blah. But what I thought was really tricky about this was D. So, for example, the reduction in LDL receptor degradation, PCSK9 inhibitors, right? It stops breakdown of your LDL receptors so that they can be recycled. You knew this one right away. That's what statins do. Inhibition of intestinal cholesterol absorption, another way of them saying this is it's blocking cholesterol reabsorption exogenously from like the intestines. So those are your cholesterol, that's your ezetimibe one. That's your cholesterol binding resin. D, so I actually thought this was kind of tricky, so I'm gonna uncross it off. But then we'll go down to F. So F, formation of your bile acid complex. This is your bile acid binding resins, which it's not doing. Like, and you cross that one off pretty early on as well. So I thought this was tricky because remember, fibrates, they increase LPL because remember, they're really good at breaking down triglycerides, really good at it. Two, they upregulate PPAR alpha. And PPAR alpha, so deactivation of, well, I guess I actually think I read that too fast because they upregulate PPAR, not deactivate. But in general, I still think that's tricky because fibrates don't work to deactivate. I'm going to change that before I send that to you. But if this said like activation of these peroxisome proliferator activator receptors, that's also correct. But that's how they upregulate HDL. This is like the expected beneficial effect of this drug. And if you look at this patient, what's really bad on them is the triglycerides are super high. That's actually probably what's causing the pancreatitis. Because remember, if you have really, really high triglycerides, you can get pancreatitis from that. So these triglycerides are very high. So you would expect like, and HDL is like, it's like normal. It could be higher, but it's not bad. It's still like within normal range. So I would say like this, even if this said activation, like upregulation, activation of your PPAR receptors, which is what fibrates also do, the expected benefit would be to decrease triglycerides rather than increase HDL. So like you would still end up picking upregulate LPL. Does that make sense?
Mhm.
And I have seen them do this before. That's why I didn't even read this because I got excited. I'm like, oh, they've done this. Because they'll do this because it's like they do both of these mechanisms, but it's like which ones would cause the most benefit to this patient? And you're like, ah, it's so tricky. So that would be an example. The issue here is the triglycerides. It's not the HDL, and they even further help you like get to this point, this understanding, because they also tell you the patient's pancreatitis. Elevated triglycerides causes pancreatitis. So you're like, okay, this is a triglyceride issue. This is not a low HDL issue. Okay, and they talk about this here. Um, Yeah, and then again, so still a lot of people pick this one because I think that they still just remembered, your PPAR alpha, but it is activation, not deactivation. But even if this said activation, I am pretty confident this still would not be the correct answer because the expected benefit is what's happening with the triglycerides in this instance. And then here's all the other ones, kind of, but we've talked about all of these. Um, but yeah, that's that.
That was helpful. Thank you.
Good.